Colleagues, it's a pleasure to be here, and I thank both Professor Rikha and Professor Vijay Sharma for those kind words which are not entirely true. I think I stand to gain a lot more by coming here than I can give, but all the same, it's a pleasure. Colleagues, acetabulum is a subspecialty which reveals its secrets very, very reluctantly. And what we aim to do here is in steps, and my job is to familiarize you with the radiological assessment and how it correlates with the classification. So we'll see the importance of pelvis AP and Jude views, the CT scan, how it contributes to our knowledge in making it a comprehensive affair, how it all correlates with the classification, because it all gives a pointer to the kind of management you might be contemplating. So I think first thing we should throw out of the window is this term, so-called central fracture dislocation. There is no such term as a central fracture dislocation. We need to assess the injury and then assign it a proper name, because only then we know what kind of trouble we are dealing with and also how we are going to tackle it. The fracture of acetabulum depends on the type of the force vector that goes through the acetabulum at the time of impact. Vast majority of the acetabular fractures occur as indirect injury through the impact on the knee. Some are because of fall on the greater trochanter, but majority are because of the indirect injury through the femur, which acts as a ramming rod to the acetabulum. Now you can imagine that the moment I change my position of the femur and the impact, in a flexed adducted position, an impact here would go through the posterior wall. The more I abduct, externally rotate, more the head goes towards the center, or in extreme position even from the anterior part of the. So in an externally rotated abducted femur, if I get a direct impact, it will cause maybe anterior wall, anterior dislocation, anterior column fracture. So almost with the knowledge of our forensic science, we can make out from the injury what kind of impact at the time of injury the patient must have suffered. Why do we need classification? It defines the nature and severity of the injury. It gives a indication as to what kind of approach, treatment and prognosis you might anticipate, and also it is a research platform so that everybody talks the same language. Needless to say, the most widely accepted classification is this Jude and Latournal. So these are 5 simple patterns. You don't need to rattle all these. It's really simple. A posterior wall fracture and a posterior column fracture. The difference is that obturator ring remains intact in the wall fracture, and it gets broken in a column fracture. Similarly, with the anterior wall, intact obturator, broken makes it an anterior column and a transverse fracture. Transverse fracture goes through both the columns, but it is not a both column fracture. We'll come to that in a minute. So remember that simple patterns, there is only a single fracture line. That is how these patterns are enumerated. Then what happens is you combine 2 elements of simple fracture. So it is more than one fracture line, 2 elements. So to complete the picture, they are called associated. So there is something and there is something associated. So you can have a posterior wall with a posterior column fracture. You can have a transverse fracture with the posterior wall. You can have a T-shaped, a transverse fracture which has a vertical limb because obturator foramen is broken, that makes it from a transverse to a T fracture. It still is not a both column fracture because part of the weight bearing dome is still connected via the sciatic buttress to the axial skeleton. The difference between the both column and T-shaped fracture is this, that in a both column fracture, no part of the weight bearing dome is attached via the sciatic buttress to the axial skeleton. So this is the basic difference between a T and a both column fracture. So theoretically you can say, yes, the posterior column is broken, anterior column is broken. So long as there is even a small area of the weight bearing dome, we cannot label it as a both column fracture. And then just to complete the picture, you have this anterior with the posterior hemi-transverse, because you see this is one of the rare, very uncommon fractures. So this is just for completion's sake. Okay. I really feel that if nothing else you should take from here, it is how to read a pelvis AP X-ray. I promise you, if you learn this,